Hello.
Good
Hello,
afternoon,
everybody.
Tibor.
Hello, everybody. This is the next issue of the WHO Standard of Practice Committee running Promoting Best Standard of Practice series. We started formally with small bowel endoscopy with 2 parts, and we are now in the upper GI, where first we had a diagnostic part. Now we will have a bleeding part, and in December we're planning the next is about the therapeutic in the upper GI. My name is Tibor Gyökeres. I'm the co-chair of the WHO Standard of Practice Committee. Unfortunately, my chair, Edward Despott, maybe will not join us together because his main interest is ESG. As you know, ESD is, as you know it, and the last one is still in progress. So we will do before without him. So today we will have 2 excellent lecturers. One about non-variceal and one about variceal bleeding. First, we will start with Jan Gralnek, Professor Gralnek. He's a professor of medicine and gastroenterology at Rappaport Faculty of Medicine, technician, Israel Institute of Technology, and chairman. Alan and Pinchas, member of Institute of Gastroenterology and Hepatology at Emek Medical Center, Afur, Israel. But you maybe know him as the ESG current president, and of course he served formerly as a chairman of American Society of Gastroenterology International Committee, Research Committee, and still serves on numerous editorial boards of main endoscopy topic journals. Jan.
Tibor, thank you very much.
Before you start, may I get it that during the webinar you have a possibility to put questions, but please do not use the hands and the raise question, but use the question and answers. And after the 2 lectures, we will discuss all and try to answer all of the questions that we will have. Jan, please.
Tibor, thank you very much for the very kind introduction. Thank you to the WEO and to Ed Despott for inviting me to give this talk on GI bleeding. Let me share my screen here. Let's see. Are you seeing my screen?
Yes.
Okay. Let me move this out of the way. Okay, so thank you everyone for joining. We're going to talk about non-variceal upper GI bleeding, and really I'm going to focus mainly on peptic ulcer bleeding, but of course I'll be happy to answer questions on other causes of non-variceal upper GI bleeding. This is my COI statement. I'll do this as a case presentation. This is a pretty typical case. I think most of us see. 78-year-old gentleman. He has a history of coronary artery disease. He had a stent placed just a few months ago. He's had melena now for the past 24 hours. And because of his stent, he's on a dual antiplatelet therapy. He's also on a statin and a beta blocker. But he also tells you in his history that he's recently been using NSAIDs because he's had sciatica. And initially, his vital signs, laying down, he's slightly tachycardic. His blood pressure is 99 systolic. But when he stands up, his heart rate jumps up to 121 and his systolic blood pressure falls to 82. So he appears to be hemodynamically low. In other words, volume down and orthostatic. His hemoglobin, at least initially, is 9.1. He has a baseline hemoglobin of 14.1. So I think all of us initially, even when we're taking the history, need to think about a checklist prior to doing upper endoscopy, that we should be risk stratifying the patient at the time of presentation. And I'll go into this a little bit more detail. We also need to, of course, volume resuscitate these patients, initially using crystalloid fluids. Today, if they need a blood cell transfusion, we should be following a restrictive blood cell transfusion strategy. We can consider giving these patients an upfront IV PPI. If they're on antithrombotics, whether that's antiplatelet agents or anticoagulants, we need to be managing those medications. We can consider a prokinetic agent before endoscopy. I'll talk about that more. And then upper endoscopy, the current recommendations for non-variceal upper GI bleeding is these patients should be scoped within 24 hours of the time that they present. And this should be done after volume resuscitation, as well as after taking care of their other potential comorbidities. So risk stratification, we should be doing this at the time of presentation. The risk stratification tool that has really been most used and published is the Glasgow-Blatchford score. We know that low-risk patients, so score of 0 or 1, we actually consider those patients for outpatient management. Those who have a Glasgow-Blatchford score of 12 or greater are considered to be at a high-risk bleeder and at high risk for poor outcomes. This is just the Glasgow-Blatchford score on the left with the various variables. And as I've said, we can potentially manage low-risk patients on an outpatient basis. So what about hemodynamic resuscitation? We should be starting with crystalloid fluids, using 2 large bore IVs to get these patients adequately hemodynamically resuscitated before we do endoscopy. We can even consider using a central line if necessary. For suspected variceal bleeding, I know this is not my topic, and Mostafa may talk about this as well, is more of a gentle IV hydration so as not to potentially exacerbate variceal bleeding. But for non-variceal, 2 large bore IVs, central line if needed, and IV crystalloid fluids to resuscitate them. What is a restrictive blood transfusion policy? We know from now randomized controlled trials as well as a meta-analysis that when we restrict the amount of blood cells transfused, we actually can improve outcomes. So we can reduce all-cause mortality and we can reduce rebleeding rates. But what does that mean, restricted blood transfusion? In other words, when should we transfuse these patients with packed red blood cells? The current recommendation is for patients who otherwise are quote unquote healthy or don't have any vascular disease. We actually can wait till the hemoglobin drops below 7. For those who do have cardiovascular disease, we should transfuse them if their hemoglobin drops below 9. And this is after these patients are volume resuscitated, so we see really where the hemoglobin falls to. Should we be giving a pre-endoscopy proton pump inhibitor? This is actually a renewed or updated Cochrane meta-analysis. It was published a couple years ago. It's actually a reevaluation of the original Cochrane meta-analysis that was published in 2010. There are no new randomized controlled trials here. It's the same data, but they redid their analyses. So 2,200 subjects looking at the role of giving a PPI either orally or IV versus placebo or an H2 blocker or no treatment prior to upper endoscopy in patients who present with acute upper GI bleeding. What was really found is that pre-endoscopy PPI use likely reduces the need for endoscopic hemostasis. It's just slightly significant looking at the odds ratio. Pre-endoscopy PPI use may reduce rebleeding, although this is not significant because it crosses 1, the odds ratio crosses 1. And a pre-endoscopy PPI use may not reduce mortality or surgery or the prevalence of high-risk stigmata that we see at the time of endoscopy. So the issue is, and I'll go back to the slide, is that probably it helps or possibly IV PPIs help, and that we usually give them, but there's really not black and white or hard evidence to support their routine use, to be very honest. What about antithrombotics? We saw this patient I presented, he's on dual antiplatelet therapy. But we need to consider patients who also may be taking anticoagulants. What do we need to be recommending to the emergency department or to the surgery department where these patients are admitted to? Let's first talk about aspirin for primary cardiovascular prophylaxis. The aspirin should be held at the time of presentation in these types of patients. And if it's clinically indicated, we can restart the aspirin within 3 to 5 days. If aspirin is really not clinically indicated for primary prophylaxis, don't restart the aspirin. There's no need to do that. Another group of patients, which is more significant, are those patients who are taking low-dose aspirin alone for secondary cardiovascular prophylaxis. So patients who had some type of a cardiac event and they're on low-dose aspirin on a daily basis, we should not be interrupting their aspirin in the face of GI bleeding. If the aspirin is interrupted, it needs to be restarted within 3 to 5 days because you do not want to lose the antiplatelet effect. And there have been several papers. I'm not going to show you those data, but there have been several studies, including a randomized controlled trial that has looked at this, and the patients who were kept off their aspirin had significantly higher mortality and significantly higher cardiac events. So these high-risk patients for cardiac problems need to be kept on their aspirin. The other group are those like our patients who I presented, who are taking dual antiplatelet therapy. We should not be interrupting their aspirin. You can temporarily interrupt the second antiplatelet agents such as Plavix or clopidogrel. Sorry about that. And that should be restarted within 5 days. If you have questions about this with these patients who are on dual antiplatelet therapy, you can consider consulting with your cardiology colleagues. In terms of anticoagulants, there's not a lot of data, not nearly as much data or high-level evidence. For those patients who are taking vitamin K antagonists, we can give low-dose vitamin K or IV PCC or FFP. For those patients who are using direct oral anticoagulants, in patients who really have a massive bleed, we can consider using a reversal agent or giving IV PCC. In this type of a situation, if you do have questions about using a reversal agent, you can consult your hematology colleagues. Usually they oversee the reversal agents. What about residual blood or clots that are obscuring our view at the time of endoscopy, or you're concerned that your endoscopic view may be compromised? We can use a promotility agent such as IV erythromycin. That's the medication that has the most data. There have been meta-analyses that have actually shown that when we give IV erythromycin, it can improve gastric visualization and reduce the need for second look endoscopy, but there really doesn't improve initial hemostasis or rebleeding in those patients. If you are going to give IV erythromycin, the current recommendations are to give 250 milligrams IV about 30 to 90 minutes before endoscopy. Erythromycin is a motilin agonist, so it facilitates gastric emptying. We should not be giving it to patients, of course, who have a macrolide allergy or who have a known prolonged QT interval. What about active hematemesis in patients prior to endoscopy? So the current recommendations from the European Society of Gastrointestinal Endoscopy is to suggest endotracheal intubation really only in patients, selected patients, who have ongoing hematemesis, who you're very concerned that they could aspirate into their lungs, patients who are encephalopathic, who are very agitated, or patients for some other reason who have an inability to control the airway. We should be prophylactically intubating those patients prior to upper endoscopy, but then we should be extubating these patients as soon as it's clinically safe. Before we get to the endoscopy, when should we be doing endoscopy? I told you most patients' current recommendations is we should be performing upper endoscopy in suspected non-variceal upper GI bleeding within 24 hours of the time of patient presentation. These are the recommendations from the European Society of Gastrointestinal Endoscopy. We do not recommend what we define as urgent endoscopy within 12 hours because as compared to early endoscopy, and the Laos study randomized controlled trial showed this, the outcomes are not improved with earlier endoscopy. And we do not recommend, the European Society does not recommend emergency endoscopy within 6 hours because there's actually data to show that you could have worse patient outcomes, probably because these patients are not adequately hemodynamically resuscitated and their other comorbidities are not adequately taken care of prior to upper endoscopy. The American College of Gastroenterology and their guidelines also suggest that patients admitted to or who are under observation for upper GI bleeding should undergo endoscopy within 24 hours of presentation. This, however, is a conditional recommendation. They earlier, on an earlier guideline, had suggested that patients who are considered to be high risk should go have upper endoscopy even sooner. They've actually taken that out now of their recent guideline. So what about endoscopic management? I'll show you some videos here. We should be performing endoscopic therapy in patients who have active bleeding and visible vessel. We can be considering endoscopic intervention in those patients who have an adherent clot. Patients who have a pigmented spot or a clean-based ulcer do not require endoscopic intervention because their chance of ongoing bleeding is very, very low. There is a recent study looking at the Forest classification showing that potentially artificial intelligence may be better than what we are able to evaluate endoscopic stigmata in peptic ulcer bleeding. It may improve our overall accuracy, and it actually may be especially important and useful for junior endoscopists who may not have much experience. And I think we're going to see more evaluation of the Forest classification using AI in the coming couple of years with other publications pending. So what's in our hemostasis toolbox in 2024? We have all these various injectables that we can use. We have mechanical therapy such as through the scope clips and cat mounted clips. We also have band ligation devices. We have contact thermal probes, both bipolar as well as heater probe, hemostatic forceps, and argon plasma coagulation, which is non-contact thermal therapy. We also have topical agents such as hemospray and Next powder, also gels such as Purostat and Endoclot, which is also a powder. So for non-variceal upper GI bleeding, is there global consensus on endotherapy? I would say overall, yes. This is the face page from the guideline from the ESG that was published in 2021. This is from the ACG. There's a recent publication in 2020 from the American Gastroenterology Association, also an international consensus from in the Annals of Internal Medicine in 2019, and also from the Asia Pacific Working Group. This is a little bit older in 2018, but I do recommend that you are aware of all these guidelines. The two most recent, however, from the American College and from the ESGE. So let's talk about endotherapy for peptic ulcer bleeding. What should we be doing in those patients when we do upper endoscopy and there's actually active bleeding? So this is a Forest 1A or active ulcer bleeding. Current recommendations from guidelines say that we should be really using combination therapy. What does that mean? It means to initially inject with dilute epinephrine. So 1 to 10,000 or 1 to 20,000 dilute epinephrine, as you see here around this small gastric ulcer. What that can do is actually slow the bleeding down, both by tamponade and probably from microvascular vasoconstriction. And then it can be followed by, in this case, mechanical therapy. So this is a through the scope clip that is being placed right over that very small ulcer that was bleeding. Okay, so combination therapy. Now this is a different video also using combination therapy and active bleeding, but this time this is dilute epinephrine plus contact thermal therapy using a large 10 French bipolar probe. Also, a cap can be very helpful in GI bleeding cases. If you put a clear cap on the tip of your endoscope, and especially in the duodenum, it can pull back folds and allow you to visualize the site of bleeding better. What you're seeing here is the injection of the dilute epinephrine, and you see a whitening or blanching of the surrounding mucosa. You can inject 1 to 2 cc's circumferentially around the ulcer. And then here is a 10 French probe that is being placed directly over the site of bleeding. A use of low watts, anywhere from 15 to 18 watts. You see this is still actively sort of oozing. The probe is placed on there. We should be pushing down when we use the thermal probe to push down on the vessel and to close the vessel. This is called coaptive cauterization or coaptive coagulation. As you're seeing here, we ideally should be holding that for 8 to 10 seconds. So this is just a schematic of what that looks like in terms of showing you that you push down with the probe, you deliver the thermal sealing of the compressed vessel. And what you have at the end here is what's called a post-hemostasis footprint after you've cauterized that vessel. What do we do with Forest 2As or non-bleeding visible vessels? As you see here, you can use mechanical therapy, you can use contact thermal therapy, and if you want to, you can actually use dilute epinephrine prior to doing that as what is being done here. There's a little bit of epinephrine that's being injected around this area. You see the visible vessel there right in the middle. But the epinephrine can help potentially stabilize and maybe prevent bleeding after you treat this area. And then what you're going to see here, I think in this video, this was more of a fibrotic clot. So a contact thermal probe was used here. Again, a large 10 French size probe, which means you would need to have a large single channel gastroscope or a double channel gastroscope, because the 10 French size probe will not fit into a diagnostic gastroscope. And again, here, coaptive coagulation, where you push down on the vessel, low wattage, 15 to 18 watts with the bipolar probe. If you're using a heater probe, usually 30 joules. You can use 15 to 30 joules. You hold the probe in place, pushing down for 8 to 10 seconds to compress and to seal the underlying feeding vessel. You see it's being held there and intermittently being given coagulation. I'll just keep letting the video run for a minute. Let's see at the end here. And you want to flatten out that site. Just some coagulum there. What about adherent clots? There's no consensus on adherent clots. If you feel comfortable treating endoscopically, you can do that. If you don't, then you may want to put these patients on high-dose IV PPIs. This is a video that shows a nice adherent clot here in the duodenum. If you're going to treat this endoscopically, you need to pre-inject with dilute epinephrine around this area. An adherent clot is a clot that cannot be suctioned off or washed away with vigorous water jet solution. So in this situation, this clot did not move. And then you're going to see here that there's going to be epinephrine, dilute epinephrine, 1 to 10,000 or 1 to 20,000 that's injected around this area, again, to stabilize the underlying site of bleeding. You see there the mucosa is getting white from the injected epinephrine. You want to inject around the ulcer. I do not inject into the ulcer. I usually inject around that area. And then what you can do is I will use a mini cold snare to gently take off the clot, to remove the clot, to reveal what is under the clot there. You're going to see that here momentarily. I actually prefer to use a thin wire for a dedicated cold snare, polypectomy snare. You'll see this in a minute. This is actually a braided snare that is used here. But again, the key here is to gently take off this clot after you've pre-injected with epinephrine. So this snare is placed around the clot. And then gently you can cut the clot away, but doing this gently. And then you'll expose what's underneath. Sometimes it actually may bleed despite the use of the dilute epinephrine. You can close the snare on there. I'm going to move the video up a little bit, and now the clot is gone. You see what's underneath there. And then this situation, there's probably a little bit of clot that's there, but in this situation, the ulcer appeared quite fresh. The mucosa appeared to be quite pliable. It wasn't too fibrotic. So through the scope clips were used here to close this up. There's a total of, I think, 3 clips that are going to be placed here. This first one here, you see that the mucosa, you can really grab onto it nicely with the through the scope clip here, and then and have this closed. There's one, and we'll move it forward. And you'll see here at the end, there's a total of 3 clips that were placed, and the ulcer there also was very nicely closed there. Okay. One word, epinephrine injection alone is not adequate as definitive endotherapy. If that's the only thing you have, then that's fine. Then you should go ahead and use that. But otherwise, we should be using epinephrine in combination with an additional hemostasis modality. What about persistent bleeding? All I'm going to say here is a couple things is that if there's active bleeding, you can actually use a topical agent, whether that's hemospray or next powder. You saw that there was in an induction, the active bleeding was induced here on the left, and it was decided to use a hemospray to try and stop that. The other option here is also to basically use a over-the-scope clip. I'm going to go through a little bit faster because I want to save time for the other lecture. This is a very fibrotic, large duodenal ulcer that is being injected. There's actually, you can see through the scope clips here down at the bottom that was not stopping this. The through the scope clips were not strong enough, and it was decided to use an over the scope clip in this situation. And I'm going to show you here that go back a little bit. The over the scope clip has now been placed on the endoscope, and the site of bleeding, you're going to see here in just a second, is right there. And you want to center that right in the middle and suction that area into the cap. And then you can deploy the cap. It's very much like band ligation, but you really have one shot at it. So there is a learning curve that is involved with using an over the scope clip. And now I'm going to show you here after the cap has been taken off, you see this large amount of tissue that has been taken up and the bleeding has been stopped. This is a very large fibrotic lesion, and I think that over the scope clips, this is a great use of them in these types of lesions. So technical tips for peptic ulcer bleeding to close out: a therapeutic single channel or double channel gastroscope I really think needs to be used. A clear cap can be very helpful to identify the lesion and assist in stabilizing the scope and allowing you to treat with hemostasis. Water jet for washing. If you're going to use a contact thermal probe, use a 10 French large size probe. For large fibrotic ulcers, considered a cap-mounted clip like the over-the-scope clip. For persistent bleeding, we can also use a cap-mounted clip or a topical agent powder. And I really think today we need to have 24/7 coverage of an on-call endoscopist for these cases, as well as a nurse who's trained in endoscopy and trained in hemostasis to assist us. Post-endoscopy management very quickly. For peptic ulcer bleeding, we put these patients on high-dose PPIs for 72 hours. We can start them on clear liquids. If it's peptic ulcer bleeding, you want to test and treat for H. pylori. We need to always remember they're antithrombotics. Rescope the patient if recurrent bleeding happens. We should not be routinely rescoping these patients, only if they have clinical evidence of recurrent upper GI bleeding. If endoscopy is not working, we should be calling our interventional radiologist to send them for angiographic embolization. And really today in 2024, it's pretty uncommon that we need to call surgery in these types of cases. I am going to make Tibor as the president of the ESG. I must advertise ESGE days, which will be taking place in April in Barcelona. It's 3 days of everything endoscopy, from basic endoscopy to very advanced endoscopy. We're expecting almost 5,000 on-site participants in Barcelona, and I invite all of you to join us there. It's a really great conference, and I'll stop with that and thank everybody for their attention.
Thank you, Jan, for your excellent lecture. It was very clearly demonstrated endoscopic hemostatic methods, and it was like case-based session, so it was very useful. And I call attention of the attendees that please use question and answers. And after the second lecture, we'll try to answer with the experts your questions. Our second lecturer concerning variceal bleeding will be Dr. Mostafa Ibrahim, who is an assistant professor of Theodor Bierhaus Institute, Gaza, Egypt. He's still a visiting consultant at Abbas University Hospital of Brussels, head of endoscopy unit at Mir International Hospital, and as you know it maybe more, is a founder of Roya Training Center, which runs a lot of sessions, a lot of courses all around the world, and she is still active in international field as an international committee chair for American Society of Gastroenterology. Mostafa, unfortunately, is still in the air. He did not land it, but he's a good guy. So he sent his preloaded presentation. So I asked the secretariat please start the Mostafa's lecture. Thank you.
Okay, good afternoon, everyone. My name is Mostafa Ibrahim, and I'm really very proud and honored to be invited by the WEO and the Best Standard Practice Committee to give this lecture about variceal bleeding. So really, varus is totally different than other than non-variceal bleeding. If I would like to conclude my presentation in one word, yes, we have a gap. So yes, we have a gap in the literature, in the practice. There's a lot of difference, but what's happening in the real practice as well as in the guidelines and the literature. So I think it's very important subject, and I would like to thank really Professor Ed Despott for inviting me for this lecture. So number one, yes, we have already heard about the non-variceal one. Yes, we have two main reasons of upper GI bleeding, the variceal bleeding and the non-variceal bleeding. If I would like to choose one important just box from this all of this pathway of the patient, from resuscitation to risk stratification, to endoscopic pre-management to the endoscopic management, and then to the secondary management. For me, the most important thing in non-variceal bleeding is the pre-endoscopy management, because this is you need to put in your mind, it's a totally different patient condition. This is the cirrhotic patient, HCV, HCC, hepatorenal syndrome, ascites, a lot of comorbidities. So this patient is very fragile patient. This patient, when start bleeding, really we need to do everything before the endoscopy to stabilize this patient. So this is really the secret, because this is a totally different patient. This patient, when had a very few hours of liver ischemia, this will already push him to encephalopathy and to other complications. So this is how I always teach my fellows, please concentrate on the pre-endoscopic management part. So the question is, do we have a gap in the management hierarchy or a defect? The answer is 100% yes. So this is a lot of studies showing that till date, by all what we have in terms of technology, in terms of guidelines, in terms of even physician technical skills, we still have a very high mortality rate at 6 weeks for the variceal bleeding, which means there is few things in the puzzle still missing. So what I'm going to do during my presentation, I will show always what Baveno, the most popular guidelines, said in each part in the journey of the variceal bleeding patient, and then what we are doing on the ground, and then to assess the gap. So for the blood transfusion, so the Baveno stated that we need to follow the restrictive blood transfusion, which means to keep the hemoglobin between 7 and 8. So this is very important. Again, put in your mind, this is a totally different idea. This is a totally different patient, the patient of the circulation, the portal circulation, the portal hypertension, and the collaterals. It's totally different idea than the normal non-variceal bleeding. So this patient, when they have this shunting and collaterals, and then when they have increased the intravascular pressure, they will rebleed immediately. So this is very, very important, especially in variceal patient, to keep this hemoglobin around 7 and 8. So how I do it in real life? So how I do it in real life, when we receive the patient in the emergency room with a hematemesis and as a cirrhotic background, number one, this is what I do in real life. Number one, I ask my fellows to do the airway protection. Why? Because ulcer bleeding, we have just this very small bleeding that the patient, even if he had hematemesis, he will just vomit few amount of blood. In variceal bleeding, it's really you have huge amount of blood. So if the patient really vomited and aspirated, this patient can die immediately in the emergency room. So why? So this is number one. We always have to protect the airway. Other thing, the bleeding or the hematemesis of the variceal bleeding is always the clotted blood. And this is even worse regarding airway obstruction. So airway protection. Number two, two wide bore IV lines, two wide bore cannulas. Why? Because simply this is saving patient life. This patient, this cirrhotic patient, can collapse from a patient with a blood pressure of 90/50 to 0 in less than 20 minutes, 10 minutes. So this is, and then when you have the vascular, the vessels collapse, you cannot put any access to the IV access. So it's very important to have early IV line. Then the most difficult part, nasogastric tube. So if we go to the guidelines and the literature, they will say you should not put a nasogastric tube in a variceal patient for the theoretical risk of injury to the varices. I've been putting this on my fellows and my colleagues for the last more than 20 years now. We have never seen this. So this is something that it's very gray, I would say black box in the literature. That's a theoretical risk of this injury. However, on the other side, what is the importance of this? Number one is to have to clean the stomach, because in a lot of countries still erythromycin is not there. Number two is this is one of the markers to understand that this is really an active bleeding or not. Then urgent labs, and then very important, call the on-call, which is a very simple admin job. However, if you don't have an on-call endoscopist ready to come within the next 12 hours, you should not admit the patient, because if you admit the patient, this patient cannot stay. Again, just one step back. This patient is the cirrhotic patient with liver ischemia, with ascites, with renal insufficiency. So this patient should always be managed in the proper time. And then ICU admission for sure. And then, as I said, we follow the restrictive blood transfusion. Antibiotic prophylaxis. So Bavin stated that we need to start antibiotic prophylaxis at admission. We normally go with, this is the guidelines, we go for third generation cephalosporins. What we do in real life, also, it's very important. This patient is a very special patient. This patient is the patient who is admitted to the hospital a lot. Sometimes for bleeding, sometimes for encephalopathy, sometimes for hepatorenal syndrome, sometimes for peritonitis, sometimes for other things. So this patient had a lot of resistance to antibiotic. So this is why what we do in real life, when the patient came, reach the hospital, we do blood culture, urine culture, sputum culture. We start the ceftriaxone, the third generation cephalosporins, and then we adapt to change according to the results of the cultures. This is the $1 million question. So again, Bavino, ESGE guidelines, ASGE guidelines, WA recommendation, WGO, everyone is recommending we need to start vasoactive medication as soon as possible. This is what I do. And then to continue them for 5 days. However, just one step back, which one of them? So the vasopressin, terlipressin, somatostatin, octreotide. When I was fellow, I had the impression, okay, if it's really massive bleeding, we will go for terlipressin. If it's less bleeding, we will go for octreotide. But after this very famous meta-analysis, this showed that all of them, you should use whatever you have in the hospital, but you should use one. How we do it? Again, even if we know from the meta-analysis that you can use anything. What we do always in Egypt, we start by octreotide as a bolus dose, and then we put the patient on IV octreotide. However, still, if the patient had a hepatorenal syndrome or very massively bleeding on the octreotide, we sometimes change for terlipressin. When to stop this? We stop it 24 hours after successful endoscopy treatment, which is a very big debate in the literature. And my personal view from this. So it depends on the endoscopy. It depends really. When you give the vasoactive medication and you stop the bleeding, and then the patient will go to endoscopy with a very good endoscopic hemostasis, there is no really big need to continue this. But this is the literature, yes. Most of the literature coming from hepatology centers that they are doing, I would say, less endoscopy. However, this is a very big debate. Even after the Bavino and after the guidelines, you still see a lot of RCTs comparing 2 days versus 3 days, 1 day versus 5 days. My very important message here is endoscopic hemostasis. You need to reach endoscopic hemostasis. So what we do endoscopically, number one, as I said, timing, we need to understand a lot of things. It's not only just me as endoscopist to go, it's me, the nurse, the supporting staff. Other thing, sorry, we should not go very early and we should not go very late. Why? Because if we go very early, in varices, especially in esophageal varices, you see the blood, you cannot see the source of the bleeding. And then there is a lot of studies also show that this is even will make you to put the bands in the improper position or way. So this is, again, another very important question. One, I will always teach my fellows, okay, this is when the patient is hemodynamically stable. Yes, there is the debate in the endoscopy. You can see a lot of studies. This is a study, for example, comparing very urgent 9 hours versus 24 hours, and you can see no difference. Another multicentric study showing that if it's before 12 hours, again, this is no difference. So I would say from all these different studies, it's very important. I will keep always my patient around this 12 hours window. However, it's very important not to do it very early, as I said, because when you put it very early, you have the problem of incomplete treatment, or I would say improper treatment. But the hallmark is patient resuscitation and hemodynamic stability. So this is what we do. We do ligation, band ligation. This is the standard of care, and we follow all the guidelines within the 12 hours. How we do band ligation? We always start at the cardiac. We put our band. I use always the 6-shooter band, not the 4 and not the 10. This is especially because of the size of the cap. This is the optimal size. Start at the cardium. Start doing your band, doing this zigzag. So I'll start, let's say, at the cardiac at 12, first band, pull back 1 centimeter, go to 3, another band, pull 1 centimeter, go to 6, and pull 1 centimeter, go to 9. So I will do this zigzag maneuver, always starting from cardia till 2 things. So till this is another very, very open question. Till we obliterate the varices, till we finish the bands, the 6-shooter bands, till we have till a 20 centimeter. Again, if you go deeply in the literature, this is another very, very open question. So as I said, how many bands, actively bleeding or not, combined with the gastric or not, and follow up. So I'll give you here my own practice. However, this is very open question for the literature. How many bands? I put as much bands as I can to obliterate the varices. So I can use sometimes 2 sets of 6 bands suture. Actively bleeding or all, if the patient is spurting bleeding, I will band only over the spurting bleeding. I stop, and then I follow this patient after a couple of days to do the rest of the varices. If the patient only have no spurting bleeding and only a nipple sign with some bleeding signs, I will do all of them, but I always start my first band on the nipple sign where I aspirate this bleeding point inside the band. And then technically, when you aspirate this, most of the cases you have this bleeding in front of you. You have this bleeding in front of the lens of the scope. Don't stop. Continue suction and then release the band. Combined or not, this is another $1 million question. So if you have esophageal varices and gastric varices, so you need to understand this gastric varices is an isolated gastric varices, or this is continuation of the esophageal varices. If it's continuation, you need to assess if the bleeding is originating from the esophagus. So this means that you need to treat both of them, which means I will inject the gastric varices of the same vein, and then I will do the band ligation in the esophagus. Why? If you do only the band and you leave the extension non-treated, this will increase the pressure in this gastric part, and then spurter bleeding will happen here because the flow coming from gastric to the esophagus. And then follow up, again, the guidelines and the literature is very open. Some people are doing every 2 weeks, 10 days, 1 month. I always go for the 2 weeks, and then when I have the 2 weeks, if I have even some post-band ulcer, I will band the rest of the varices if they're between the ulcers. So the gastric varices, again, all the guidelines are recommending the obliteration with cyanoacrylate. A lot of studies showing that this is now the best that we have in terms of treatment option. Again, this meta-analysis very clearly years ago confirmed that in favor of cyanoacrylate. So the Baveno confirmed. So this is also another I will not say debate, but this is something that we do a little bit differently in the guidelines. So for the GOV1, you can do band ligation or gastric or cyanoacrylate injection. GOV2, IGV1, and IGV2, it's cyanoacrylate. What we do in real life, it's always anything below the gastroesophageal junction, which the four of them, we will do cyanoacrylate injection. So this is an example of a retroflexion. So it's very important, the steps. Step number one, probe the vein. Step number two, make you are sure you are ready. You are already prepared outside the number one, the lipidol. Number two, the mixture of lipidol with cyanoacrylate, and then the flushing with distilled water. So now I'm injecting very rapidly the mixture. And a very important tip, and then now I'm flushing by the distilled water. And while flushing, I take my needle out. You will see now, I will flush a little bit more to make sure that my needle is working. I stop. This is where your adrenaline, you should really stop your adrenaline rush here. Wait for 2 minutes, and then probe the vein again, and then it will be very solid. Why to wait? You need to give the time for this molecule to start active and to start polymerization. The problem always of embolization happens here when you have this adrenaline rush and you're injecting more and more and more and more. So inject the first shot, which is 2 ampoules of cyanoacrylate, 1 milliliter, 1 milliliter of lipidol, flush, wait, and then if you need more, you can do more. However, this is what we are doing. Again, a lot of open questions. How many milliliter per injection? We do normally 1 milliliter of cyanoacrylate in each vein with the lipidol. Concentration, should we do only 1-to-1, which means 1 milliliter of cyanoacrylate versus 1 milliliter of lipidol, or we have the 0.7, which is the more, let's say, more viscous, I will say. Actively bleeding or all, I will always go for the actively bleeding. I will never inject a non-actively bleeding vein if the patient in hematemesis. Combined treatment, yes, we combine sometimes with esophageal varices, especially in the extensions, and then follow up. We do the follow up after 2 to 3 weeks. Other things that now I'm doing a lot is the EOS coiling. So this is one of the patients that I did last year. So the beauty of this examination that you can see every time in real time. So this is the Doppler effect, and then you calculate really the vein. I use a 19 gauge needle inside the varices, and this is very important. This should be done in non-actively bleeding patient. After that, I'm putting the coil here. After the coil, we only inject 0.5 milliliter of cyanoacrylate. This is more than enough because this coil will act as scaphoid for the polymerization of the molecule itself. And then the beauty of the exam, that when you finish, you put the Doppler immediately, and you know that you obliterated the vein. So this is something I'm doing a lot nowadays. So yes, as I said, real-time injection and obliteration. So do we need really something different? The answer is yes. Still, put in your mind that you need to stabilize this patient as soon as possible, especially to avoid liver ischemia and complication. So this is why during my studies, I tried this powder, the idea of having the hemostatic powders to act as a bridge therapy to the definitive therapy. So this is the RCT that we did a couple of years ago, comparing hemospray to medical treatment as a bridge therapy to the definitive treatment. So the idea, when the patient is admitted, either we go only for medical treatment and then do the definitive endoscopy after 12 hours, or on the other side, a patient will go hemospray in 2 hours, continue on medical treatment, and then we do the definitive endoscopy in 2 hours. So my last message here, This topical sprays will never change the pathology, but it will always change the patient condition. So for example, this is an actively bleeding patient that you cannot see really what is the source of the bleeding. And the beauty of this powder is really a non-touch technique. You just spray everywhere, do this hemostasis, initial hemostasis, come back after 24 hours, you will find the varices there. However, not bleeding, so in a very clean condition that you can do the band ligation. Finally, yes, still have the tips as an option, a very important option, maybe more in West Europe than in Middle East and Africa. However, we should have our friends of the radiology ready to help us when we fail to do the endoscopic management. So my take-home message, yes, early endoscopy is important. Band ligation is the gold standard for esophageal varices. Cyanoacrylate is the gold standard of gastric varices. Powder could have a very good role in this. All topical agent have a very good role, especially in changing the patient condition and having the very early hemostasis. Again, thank you very much for inviting me and for having me today, and hopefully to have a more and more with the WO in the very near future. Thank you very much.
Thank you very much, Mostafa. Unfortunately, Mostafa still not landed, so Jan and myself will try to answer the questions and discuss for the remaining minutes. The first question, Jan, what testing do you suggest in these settings? I mean, it's testing for Helicobacter pylori, I think, during the bleeding.
You're talking about for peptic ulcer bleeding?
Yes, peptic ulcer bleeding.
Yeah, you can test and treat for Helicobacter pylori. Basically, what I do is, there's data to show that rapid urase testing may be falsely negative in the face of active bleeding or a bleeding peptic ulcer. What we do is we will actually take biopsies, antral biopsies for rapid urase testing, but we also take tissue and put in a bottle to send for histology. If the rapid urase test is negative at the bedside or at the in the endoscopy suite, then we send it for histology as well to make sure that it's truly negative.
Okay, we do the same. The next question, can pathology other than ulcer or size of the lesion affect your decision?
Pathology meaning, I don't know if they're meaning like if this is a tumor bleed or something like that. I'm not sure what they're asking, but let's say it's a tumor. Let's say it's an upper GI tumor, which I didn't really talk about. Really, in my opinion, tumors generally ooze, and it's usually diffuse oozing because of angiogenesis. And really, standard hemostasis modalities are really not effective in tumor bleeding. So what really there's good data to show is that if we use a topical agent, whether that's like Hemospray, there's data on Hemospray or some of these newer powders, because it provides diffuse coverage and it basically just gives you a bridge to further therapy.
Okay, and another, maybe they ask a little bit maybe about the tumor or maybe ulcer size. Maybe you mentioned as a Kaplan in the clip, as in ESG Gralnek is a secondary modality. Is it some circumstances when you use it as a primary? Because we have a publication that it's more effective in some circumstances. Would you mention it?
Yeah, although there's the study from the Hong Kong group that looked at the use of over-the-scope clips as primary therapy in large fibrotic ulcers, so ulcers that were at least 1.5 centimeters or larger, and they did not find a significant difference. So there's somewhat conflicting data. I personally, in those types of ulcers, like I showed you that video, larger fibrotic ulcers, I would use an over-the-scope clip in those type situations, basically because through-the-scope clips are just not strong enough to grasp on the fibrotic ulcer base and to help close that area. The other thing is that if you see a visible vessel that is larger than 2 millimeters, probably the chance of adequate therapy is low, and you should really consider saying, you know what, endoscopic therapy is not indicated here, and probably we need to send this patient to interventional radiology. The other issue may be if there's poor access to the site of bleeding, or somewhere in the posterior duodenal bulb where it may be a feeder vessel from the gastroduodenal artery, also may be less amenable to endoscopic therapy, and you may want to consider just going directly to interventional radiology. If you're going to do that, my recommendation is actually to take a through the scope clip, place it near the site of bleeding, because that will actually give the interventional radiologist a roadmap for their treatment, for embolization treatment.
Okay, thank you. We have a lot of questions. Okay. Treatment choice for de la foie lesion.
You can do several things. You can use mechanical therapy, through the scope clip, over the scope clip. You can use contact thermal therapy. You also can use band ligation.
Okay. In some countries, erythromycin as a prokinetic is not available. What about other prokinetics like metoclopramide?
You can use metoclopramide or Regland. You can give 10 milligrams IV. You know, there can be side effects from that. Not common, but there can be. And the efficacy is not as good as erythromycin. If you don't have erythromycin, you want to do that, try that. The other thing, there was just a randomized controlled trial published in Endoscopy that if there's residual blood or clot, you actually can sit the patient up almost to 90 degrees, and it should move the blood, at least if you're looking at the fundus and the cardia for the site of bleeding, it does move the blood down, and it may allow you to have visualization.
Next question. Which PPI regimen would you recommend after endoscopy? Do you give oral PPI? How do you decide on switching from IV to oral?
Well, the current recommendations are to give an IV PPI for 72 hours after giving endoscopic hemostasis. Of course, you know, there's a lot of patients who are discharged after 24 or 48 hours, so they're not going to be on IV PPIs. You can give the IV PPI as continuous infusion or twice a day dosing by IV. When you transfer them to oral, basically what I will do is I'll put them on high dose oral PPI for at least the next month, and then you can reduce that to once daily dosing.
Thank you. Another question from Cambodia regarding tools of hemostasis. It's to Jan, based on your experience, have you ever used hemostatic powder to stop bleeding from GI cancer? How effective is concerning the recurrent percentages and compared to other hemostatic methods?
So it's actually probably the place where the powders are the best data we have is in tumor bleeding, both upper GI tumors as well as lower GI tumors, because it's usually diffuse bleeding. It's not definitive therapy. It basically buys you time and allows for a further evaluation of the tumor and what type of treatment they're going to have, whether it's surgical or neoadjuvant chemotherapy, whatever. But using topical agents is actually indicated for diffuse tumor bleeding because, as I stated earlier, our hemostasis, the regular modalities, are just not that effective in tumor bleeding.
Okay, one question is about the cost of the hemostatic powder. It depends, of course, by region, but it's not a cheap therapy. That's okay.
It's not a cheap therapy, but in situ, you know, for at least peptic ulcer bleeding, it's really considered to be rescue therapy. So if nothing else is working, then I think it's worthwhile to use a topical agent in those situations.
Okay, another question is maybe to Ibrahim. We should try to answer them. 30% dosage in bleeding. Is it same in the treatment to hepatorenal syndrome? If I'm not misunderstanding, Mostafa mentioned about the injection of cyanoacrylate only if it's active bleeding. What about stigmata of recent bleeding, such as red veil sign? Will you injection the coal as well?
If it's isolated gastric varices and you have stigmata on the gastric varix, I would actually treat that with cyanoacrylate.
Okay, and regarding the dosage, I think the main advantage of the terlipressin that you shouldn't calculate the dosage. You should start with 1 ampule and do it regularly. So it's the best not thinking about the patient's body weight or anything else.
Yeah, and the other thing with, terlipressin, or if you're using another vasoactive agent, is that if you're suspecting variceal bleeding, then they should be put on a vasoactive agent right away. So like in the emergency department, the vasoactive agent should be started.
Okay. Another question about tumor ulcers bleeding, use of thermotherapy. Is it possible?
Sclerotherapy?
Thermotherapy.
Thermal therapy. Again, usually it's not that effective just because usually tumor bleeding is diffuse. If you have a specific ulcer with a vessel, I guess you could use thermal therapy, contact thermal therapy on that site. But generally, if you have a mass that's oozing and bleeding, I would use a topical agent.
Okay, a question about the setting of electrosurgery for a bipolar probe in duodenum. Do you use it?
Yeah. Same thing. It's low wattage. So if you're in the duodenum, you could even go a little bit lower. I guess you could use maybe 12 watts to 15 watts. In the stomach, 15 to 18 watts. That's all considered to be low wattage. But you could, if you're worried because the wall of the duodenum is thinner, you could use to start at 12 watts. And if you don't think that's enough, go up to 15. But the key is to put it over the site of bleeding and push a little bit and hold it there for anywhere from 8 to 10 seconds.
Next question. Any experience of thrombin injection into gastric varices?
No, personally, no. They do use thrombin injection a fair amount in the UK, in the United Kingdom. Ed Despott's not here. He could maybe have told us about that. But there are data, and we do mention it actually in the ESG guidelines on variceal bleeding, which was published in 2022.
Next question. Can endoscopic band ligation be performed on esophageal varices if subcardial region cannot be evaluated due to blood or coagulum and gastric varices cannot be excluded?
Yes, I would still treat it if you think that the site of bleeding is from the esophagus, regardless of whether you can see if there's a gastric varices or not. If you think they bled from there, I think you need to treat the esophageal varices.
Okay. If patient had recently cardiovascular event and came with upper GI bleeding, do I will stop his blood thinner medication? I think that was a good summary in your lecture, but short answer.
Short answer, if the patient is, let's say, I'm not sure how recent, if they're talking about it in the hospital or if they're on heparin or something like that, you can certainly stop heparin for a few hours and then do the endoscopy, restart their heparin. I think in patients who are on aspirin because of cardiovascular issues, if they're on low-dose aspirin, you keep them on the low-dose aspirin. If they're on dual antiplatelet therapy, you can temporarily hold the second antiplatelet agent, keep them on their low-dose aspirin.
Okay. Is there a minimum platelet count for esophageal band ligation?
I mean, we always say we'd like to see it above 50,000. You could probably let it go a little bit lower before you'd have to transfuse, but the number that's usually used is you want a platelet count of over 50,000. But we do not routinely give platelet transfusions unless it's really necessary.
Okay, another question, maybe not the last coming questions. Is it possible to attempt upper GI endoscopy less than 12 hours beside resuscitation if there is a severe active bleeding? Is it possible to attempt endoscopy in less than 12 hours?
So if in patients who you're not adequately able to resuscitate. So they continue
Besides
to be,
resuscitation, it maybe that means the question.
if they're not able to be resuscitated?
Besides resuscitations, maybe it's a patient is resuscitated.
Yeah. If the patient is adequately resuscitated and, you've taken care of other potential comorbidities, you can scope them, sooner than 24 hours. You can scope them less than 12 hours. But the main thing is that you really need to have them adequately hemodynamically resuscitated before you scope them.
Okay. Question about Dennis stent. Dennis stent versus hemospray powder if blood's obstructing potential therapeutic approach.
So Dennis stent is indicated for persistent esophageal variceal bleeding.
Not a persistent, but I think if you do not see anything, it's a blood obstructing potential therapeutic approach.
Yeah, but it's used, Tibor, like if you can't get the esophageal varices to stop bleeding, or you can't really see what's going on, but you have to make sure that the bleeding is coming from the esophageal varices. You can put it in. The thing that's nice about a stent, and it doesn't have to be a Dennis stent, it can be a fully covered esophageal stent. They can be left in for 7 to 14 days, and then that allows you time to decide what further treatment they may need for their underlying liver disease, and you can take out the stent when you need to.
Okay, and Hemospray demonstrated Mostafa very clearly that can help in this situation, and you go back.
It can, and you could go back, 12 hours later. You need to go back because it's going to wash away, and you may have recurrent bleeding.
And is APC is only indicated if in gastric anterovaricial ectasia Gave syndrome?
It's very interesting. We're looking at this right now, actually, in a meta-analysis in peptic ulcer bleeding. There have been at least 7 randomized controlled trials looking at APC. The American College of Gastroenterology says you can consider using it. I personally do not like to use APC for peptic ulcer bleeding, but the data may show that it's really not any different than the other modalities that we use. So I can't give you a definitive answer. I use APC for treating Gave or watermelon stomach and angioectasias.
Okay. Do viscoelastic tests have a role in the management? In which cases would you use it?
Which one?
Viscoelastic test, I mean the coagulation test. Viscoelastic.
I mean like INR? Is that what they're asking?
INR, and I think more sophisticated than INR.
Yeah, so we don't use anything beyond INR. And we used to say we wanted the INR less than 1.5 before we treated somebody. That's no longer true. You can actually do endoscopy and perform hemostasis, especially like in patients who have underlying liver disease and they have elevated INR. Even if the INR is 2.5, that should not stop you from doing endoscopy and potentially treating the source of bleeding.
Okay. What's your recommendation about anastomotic side bleeding in immediate postoperative period, when to attempt upper GI endoscopy, and what should be the modalities may be chosen?
Depends on what immediate is. I don't know what the definition of immediate is. We don't love to actually go to insufflate immediately after surgery, but that may be less of a problem with CO2. So I would be using CO2 and not air. And I guess it depends on the lesion. I would probably also try and stay away from using thermal therapy. I would probably try to use mechanical therapy in that situation.
Okay, maybe we almost finished all questions. Just one question that the viscoelastics made it thought about the ROTEM, which is a rotational thromboelastometry, which is a holistic coagulation assay, and it is very useful. But I think this is mainly used by the intensive care therapists, intensive care therapists, they're preparing patients for the endoscopy. This is not our task to use it.
Okay.
I have one last question. Maybe we are out of time. You mentioned that the use of cap can be useful in management of the bleeding. But
Yeah.
I think when you start with a patient who came into the ward and bleeding, I suppose you do not start with cap, because if you use a cap from the beginning, it can decrease your view, and it can be useful, of course, to compress the bleeding ulcer. But when you start, you do not know what we will find. So it's a real life that you start without cap, and if you see a huge bleeding from the duodenum, cannot stop, and then go for cap. Am I right?
You can start if you want to, and if it's a problem, you can actually take your scope out, take the cap off, and go back down. Or you can do as you say, you start without it, find what's going on, and if you need to add a cap, or if you think it's going to be beneficial to add the cap, take your scope out, put the clear cap on, and go back down.
Okay. The last question, a future. Can you imagine that you are on board and the patient comes into the emergency room and they give a capsule endoscopy for the patients, and you are in the bed at home and seeing the capsule? Is it possible in the future or not?
It's potentially possible to look to see if there is fresh blood in the upper GI tract or coffee grounds. There's actually been studies that have looked at this. I was an author on a study that was published this. In fact, emergency medicine physicians can actually identify that quite well. Do I think that we are going to be able to have therapies to treat? I'm not so sure about that. You'd have to direct the capsule to treat. You'd have to have some type of a treatment mechanism. I don't think we're there yet. If we're talking about purely investigating whether there's fresh blood or recent blood there, that's another story. Yes, we can do that.
Okay. Thank you very much, Jan, for the excellent lecture and your answers.
My pleasure.
We got a lot of questions, and we were in a hurry to answer all of them. If somebody feels that did not get answer, please wrote to the W, and we will answer the remaining questions. Unfortunately, Mostafa could not join personally, and even nor Edward. But I hope that we could manage it in a good quality. So, lastly, I should thank our sponsors. May I get the last slide? Oh, the next agenda for the 3 following webinars. In December, mid-December, we'll have a therapeutic part about upper GI endoscopy, and in the first part of the next year, we will move to lower GI. And no, thank you, anything could not be happen without our kind sponsors. Thank you very much for your kind attention. And finally, you can see it on the this webinar on the WO website, and later on you can find even on a YouTube. Thank you.